The second topic is the pharmacokinetics in pediatrics. What do we mean by pharmacokinetics? It's the effect of the body on the drug. First, you take the medicine, okay? What happens to the drug after it is inside the body? We have four main components of pharmacokinetics. First, it's absorption. How will it get inside the body system? Next is the distribution, where it will go around the body. Number three, metabolism, how it is broken down, and it's usually in the liver. Number four, excretion, how it goes out and leave the body, and usually it's by the kidney. These are the four main components of pharmacokinetics. Why it's important to study about them? Because in pediatrics, pharmacokinetics can be immature due to immature body system, so we can have severe adverse reactions and toxicity, or we can have disturbed or immature pharmacodynamics. And this is not, of course, not desired in the pediatric age group. So I'm going to show you in details about the four topics, main topics of pharmacokinetics. First, absorption. What happens for absorption in the pediatric age group? Why it is special? The gastric pH is neutral in infants. It means the pH is not 2 like adults. This can affect the absorption of some drugs. Also, the rate of gastric emptying, it means the intestinal movement, not same like adults. Number three, immaturity of the intestinal barrier functions. It means the intestine is not a good barrier. Some drugs can easily pass from the intestine to the blood. So we can have high drug level in the blood leading to toxicity. An important terminology I want you to know is called the bioavailability. Bioavailability is the amount of drug that enters the circulation unchanged after oral drug administration. It is always less than 1. I mean, when you take the drug by oral route, maybe 70 or 80% are absorbed and 20% are not absorbed. So the bioavailability in the blood is 80%. So this is the bioavailability. To define bioavailability, you have to know its unchanged fraction of the drug, means not metabolized, and through the oral route. Okay, next component is the distribution. What happens in pediatrics? The protein content and binding in plasma is different for the drug. Maybe protein content is not high enough like in adults, so the amount of free drug in the blood is higher. So we expect higher effect. The body fat content. Of course, the baby has less body fat content. The body surface area, of course, it is smaller than adult. These factors affect the distribution of the drug in the body. And I want you to know this definition. What is the volume of distribution? It is the amount of space in the body in which the drug may be stored. It means which parts of the body will get the drug. It is homogeneous. Usually there is a homogeneous distribution of the drug. It means there is an equal distribution in all parts of the body. Okay, number 3, regarding the metabolism. The liver metabolic enzymes, this family of enzymes, cytochrome P450, may not be mature enough to metabolize the drugs. In metabolism, we have 2 phases. First, it's phase 1. These reactions happen in phase 1, oxidation, reduction, or hydrolysis. Here, the drug becomes inactive. After becoming inactive, the drug undergoes phase 2, which is conjugation. Conjugation means it is put on a protein. This protein, most famously, is the glucuronic acid. If there is defective conjugation, in some cases, it can lead to physiological jaundice in newborn or a gray baby syndrome known by a famous drug called chloramphenicol. To sum up for these two phases, in phase 1, there is a deactivation of the drug, and in phase 2, it is carried on a protein to be delivered to the kidney for excretion. In the newborn, sometimes these processes are not so mature. So breaking down of the drug is not mature, and carrying it to the kidney is not effective. So we can expect high level of the drug in the blood. Regarding metabolism, maybe many of you know this terminology. It's called the T-half. What is the T-half? It's the time taken by the drug in blood or plasma to decrease to its half concentration. So T means time, half means half. So it's the time taken for the drug in blood or plasma to decrease to half its concentration. Last component is the excretion. And as I said, the kidney is the main organ for excretion. Also, very known terminology is the excretion rate. It is the amount of drug excreted in urine per unit time. Also, in preterms and pediatrics, we can have some changes in the excretion rate. Okay, now we came to the third item, which is the pharmacodynamics in pediatrics. What is the pharmacodynamics? It is the effect of the drug on the body. So in pharmacokinetic, it was the effect of the body on the drug. Pharmacokinetic is the opposite relation, effect of the drug on the body. It is the pharmacological action we are waiting to happen. First, I would like to have a quick look at this graph. Maybe most of you have heard about the therapeutic index, or the TI, the ED50 and the TD50. What is the ED50? Simply, it is the dose which give a pharmacological effect in 50% of people given the same dose of drug. What is the TD50? It is the toxic dose which gave a toxic effect in 50% of patients treated by this drug. What is the therapeutic index? It is this window or this area between ED50 and TD50. As we can understand simply, if the drug is safe, then it has a wide therapeutic index. High range of dose we can change freely. But if the therapeutic index is very small or narrow, it means this drug is very dangerous. Any change in the dose, even small change, may have a toxic effect. So, why therapeutic index in pediatrics is hard to calculate? So, we can have variable and unstable pharmacokinetics. We can also have variable and unstable pharmacodynamics, and no enough clinical trial for children have been made because it's ethical issue. We cannot, ethically, we cannot try drugs in children because they are still growing. So, as I said, a narrow therapeutic index means it's a toxic drug, while a wide therapeutic index means it's a safe drug. So, pediatric age groups have a narrow and variable therapeutic index. So, when prescribing the dose for them, we have to think about this curve. So, In conclusion, pharmacotherapy in pediatrics have defective pharmacokinetics, which means high drug level. This leads to defective pharmacodynamics with increased risk of severe adverse drug reactions in children, unexpected adverse drug reactions, and so leads to toxicity because of the narrow therapeutic index. So I want you to remember this relation. Pharmacotherapy or therapeutics depends on two main items, the pharmacokinetics and pharmacodynamics, which are affected by the dose, the concentration, and finally the effect of the drug on the body systems. Okay, this is the end of my video. Thank you so much for listening.